situation with it. Sometimes you are left with no other option but to do a full thickness penetrating therapeutic keratoplasty. And whether it's a central or peripheral perforation, we are all much more familiar with the penetrating keratoplasty. And the post-operatively, we do continue with the antimicrobial therapy to protect the ocular surface, promote heat, control the inflammation, and also keep a watch on the intraocular pressure. And this was a paper what the group from AIMS have published, and looking at it, we find that in the various aspects of therapeutic keratoplasty, bacterial keratitis obviously has a higher success rate both in terms of anatomic cure and the visual outcome. The past decade has seen a resurgence of anterior lamellar keratoplasty, and we are now increasingly doing it for various non-infectious conditions wherein the Descemet's membrane is healthy, and a wide variety of techniques, both manual or automated or air-assisted techniques have evolved. Now, the question is there a role for lamellar keratoplasty in microbial keratitis? Well, when you think about it, the disadvantage is that if you do not eradicate the infected material completely, you have an increased risk of recurrence of infection as compared to a therapeutic keratoplasty where you do a full thickness cut and you remove most of the tissue. But the advantage of a lamellar keratoplasty is that you retain the healthy host endothelium, and thereby you can avoid endothelial rejection and late graft failure. As you do not enter the anterior chamber, the risk of intraoperative complications can be minimized, and we can also reduce the risk of secondary post-operative endophthalmitis. Looking at some of the papers published in literature, this was a paper long back in 2002 where they looked at the role of lamellar keratoplasty in fungal keratitis, which sounds very contradictory because we know that the filamentous fungi can penetrate deep into the cornea and sometimes very like Descemet's membrane as well. In this case, they had 55 patients where lamellar keratoplasty was performed, and the surgery was performed after 1 week of medical therapy, which is too short for fungal keratitis. Most of the patients had a favorable outcome because these were small fungal ulcers limited to the central cornea. Although 4 cases had recurrence requiring penetrating keratoplasty. If you look at a paper published in 2009 from Singapore, and they did a comparison between therapeutic deep lamellar keratoplasty and therapeutic penetrating keratoplasty for advanced infectious keratitis, and 26 eyes underwent lamellar keratoplasty and 100 eyes therapeutic. They found that the therapeutic success was equal, almost equal in both the eyes, and however with the eyes which underwent full thickness therapeutic penetrating keratoplasty, 6 developed endophthalmitis whole outcome. The visual outcome was better in the group that had therapeutic DALK compared to PKP, and the survival of the graft was also superior in the DALK group. And if you look at some of the cases where they had done a therapeutic DALK, even if a recurrence was noted, they could go back and do a repeat DALK to manage this condition, and this was really good for acanthamoeba keratitis. And in this case, one of the cases where after therapeutic DALK, large amount of exudate was still present in the anterior chamber, they treated the patient and still had a fine visual outcome. They also reported in microsporidial stromal keratitis where they did a big bubble technique going all the way right up to the Descemet's membrane, and in this single case report, the patient did well. However, this was a patient that presented to us who had undergone a lamellar keratoplasty for microsporidial keratitis, but this was not going right up to the Descemet's membrane, and we find that there is a recurrence of microsporidial interface, and we did a penetrating keratoplasty, and you can see on the east of the slide that the microsporidial cyst can be seen. What we have found in our experience is that for acanthamoeba keratitis, deep therapeutic lamellar keratoplasty really works very well. Now, this was a patient who had this acanthamoeba keratitis, vaccine really not responding to medical therapy. After 2 months, the patient was so symptomatic that she wanted some surgical intervention, and she said that we cannot treat it, remove my eye. So we went back and we did a big bowel technique, and the next day the patient was comfortable and the patient did very well. Similarly, most of these infections, once they heal, then also the role of lamellar keratoplasty becomes very important, especially if the scar does not involve the Descemet's membrane. Like this case of post-vaccine acanthamoeba keratitis that was treated left behind with a regular central scar and went back and did a deep lamellar keratoplasty. Now, this was the paper mentioning to and showing the technique where if you have decimal seals, usually when you treat corner ulcers, by the time the ulcers are responding, you can get this, hitting of the central area, and sometimes you end up with a decimal seal. In that situation, you can do a visco-assisted DA, where you go to the edge of the decimal seal and inject the viscoelastic to kind of create the plane of separation, and the residual stroma can be excised up to the point of peripheral definition, and you can replace it with a donor tissue, and you can have good visual outcome. And recently, back in 2011, another paper was published in Cornea looking at a similar technique for small and large localized decimal seals. So basically, the role of therapeutic keratoplasty is essential to eradicate the infection and maintain integrity of the globe in microbial keratitis and respond to maximal medical therapy. The advantage of anti-lamellar keratoplasty is that it avoids endothelial rejection and late graft failure. In my opinion, that we should keep it on the top of the line for, especially for acanthamoeba keratitis and certain cases of non-responding bacterial keratitis. Fungal keratitis have not advised lamellar keratoplasty. The timing of intervention is the infection to really reach right up to the limbus and then try to do a therapeutic lamellar is not going to work. So if you have a sentinel ulcer that's fairly limited, and with the use of OCT, if you can determine that the deeper area is not involved, then you can go ahead and plan a therapeutic anti-lamellar keratoplasty. That's why the timing of intervention is critical, and the surgical planning also depends on the extent of involvement. And also remember that the surgery is not just the end of the story. You have to give perioperative antimicrobial therapy to prevent recurrence and keep a close watch post-operative. I would like to invite you for the second national meeting of the Cornea Society of India, which will be in December, 21st December, in Mahabalipuram. More information on the page of Cornea Society of India.org. Thank you.